web. We can see that it is published in medRxiv, the preprint server for health sciences, and this is the web view showing titles and medRxiv. The title of the article is Casirivimab and Imdevimab in patients admitted to hospital with COVID-19. This is labeled as recovery, a randomized, controlled, open-label platform trial. And we have already talked that its sources, it is published in, if not yet to published in any journal, but it is published in medRxiv. We know that it is a medical archive, an online archive, and distributor of preprint articles, that is preprint study, and statistical object identifier is shown here. Authors are Recovery Collaborative Group. Peter W. Horby, Marion Meffam, Leon Petto, Mark Campbell, Gilhelm et al. And Peter W. Horby is the corresponding author. Aim of the study. Aim was to evaluate the efficacy and safety of REGEN-COV, that is combination of Casirivimab and Imdevimab in patients admitted to hospital with COVID-19. And this study was funded by UK Research and Innovation, that is Medical Research Council, and National Institute of Health Research. Now we are going to journal. We know that monoclonal antibodies are antibodies that have high specificity and affinity for a single epitope. And these monoclonal antibodies have been demonstrated safe and effective in selected viral diseases when used for prophylaxis, such as respiratory syncytial virus, or they may be also used as treatment, such as Ebola. SARS-CoV-2 infection is initiated by binding viral transmembrane spike glycoprotein to angiotensin converting enzyme 2 on the surface of host cell. We all know this. Anti-SARS-CoV-2 spike protein neutralizing monoclonal antibodies demonstrated efficacy in vivo in both therapeutic and prophylactic setting with decrease in viral load and lung pathology. Regeneron Pharmaceuticals in New York, USA, United States of America, developed two non-competing high-affinity human IgG1 anti-SARS-CoV-2 monoclonal antibodies, that is Casirivimab and Imdevimab, which bind specifically to the receptor binding domain of the spike glycoprotein of SARS-CoV-2, blocking viral entry into host cells. In a clinical study in non-hospitalized adults with SARS-CoV-2 infection and risk factors for severe COVID-19, this combination, that is combination of Casirivimab and Imdevimab, which is trade name as REGEN-COV, when compared to placebo, was safe, reduced viral load in the upper airway, shortened the time to symptom resolution, and reduced composite outcome of COVID-19 hospitalization or all-cause mortality. Emergency use authorization has been given for the use of other monoclonal antibodies such as Bamlanivimab with Etesevimab, REGEN-COV, and Sotrovimab in non-hospitalized patients with mild to moderate COVID-19. Till now, no virus-directed therapy has been shown to reduce mortality in hospitalized patients with COVID-19. The only published trial of an anti-spike monoclonal antibody, that is Bamlanivimab, in hospitalized patients was terminated for futility after 314 patients had been randomized. And this study showed the results of a large randomized controlled trial of REGEN-COV in patients hospitalized with COVID-19. Now the methods, study design and participant. This is an investigator-initiated, individually randomized, controlled, open-label platform trial to evaluate the effects of potential treatments in patients hospitalized with COVID-19. The trial is underway at 177 hospitals in United Kingdom, 2 hospitals in Indonesia, and 2 hospitals in Nepal. Among these, 127 United Kingdom hospitals took part in analysis of recovery trial. The trial is coordinated by the Nuffield Department of Population Health at the University of Oxford. The trial is conducted in accordance with the principles of the International Conference on Harmonization Good Clinical Practice Guidelines and approved by the UK Medicines and Healthcare Products Regulatory Agency, that is MHRA, and the Cambridge East Research Ethics Committee. Patient selection. Patients admitted to hospital were eligible for the study if they had clinically suspected or laboratory confirmed SARS-CoV-2 infection. That is suspected and lab confirmed SARS-CoV-2 infection, and who have no medical history that might put the patient at significant risk. This was depended upon the attending physician. If the attending physician thinks that the patient has significant medical history which might put the patient at significant risk, he may exclude the patient. Otherwise, all patients with SARS-CoV-2 infection, suspected or confirmed, can be included in this study. Except the patient received intravenous immunoglobulin treatment during current admission, and children weighing less than 40 kg or age less than 12 years not eligible. That is, more than 12 years children are eligible, and you have to note that even pregnant and breastfed mothers are also eligible for this study and included in this study. Baseline data were collected using a web-based case report form that include demographics of the patients, level of respiratory support, major comorbidities, suitability of the study treatment, and treatment availability at the site. At the time of randomization, presence of anti-SARS-CoV-2 antibodies checked, and the patients categorized as seropositive and seronegative. Methods of randomization and masking. Web-based simple randomization used to assign eligible and consenting patients in a 1:1:1 ratio. That is, patients were divided into 3 groups. One group received usual standard of care. One group received usual standard of care plus REGEN-COV, and another group received usual standard of care plus convalescent plasma till 15 January 2021. After 15 January, the patient on the convalescent plasma group was stopped. And this allocation was concealed until randomization. Patient or site staff don't know about the allocation of the treatment before randomization. And patients who are allocated to REGEN-COV, they receive a single dose of REGEN-COV 8 gram, that is casirivimab 4 gram and imdevimab 4 gram, which was diluted in 250 ml normal saline and infused intravenously about 1 hour. Participants and local study staff were not masked to the allocated treatment. This means that participants and local study staffs know about the allocated treatment. But the trial steering committee, the investigators, and all other individuals involved in the trial were masked to outcome data. Now the procedure. Early safety outcomes recorded by site staff using online form 72 hours after randomization. And an online follow-up form was completed by site staff when patients discharged, died, or at 28 days after randomization, whichever occurred first. Information recorded on adherence to allocated trial treatment, receipt of other COVID-19 treatments during admission, duration of admission, receipt of respiratory or renal support, and vital status. We should note that the patient who randomized to one group also randomized to other treatment, COVID treatment also. Outcomes. The primary outcome of the study was 28-day all-cause mortality. And secondary outcome was time to discharge from hospital, the composite outcome of invasive mechanical ventilation or death. This is applied for the patient who was not on ventilation during randomization. And there was some pre-specified subsidiary clinical outcome, such as use of invasive or non-invasive ventilation, time to successful cessation of invasive mechanical ventilation, and use of dialysis or hemofiltration. Now the statistical analysis. First of all, for the REGEN-COV and versus usual care, intention to treat analysis compare patients of REGEN-COV with patients of usual care. And for primary outcome of 28-day mortality, to test the null hypothesis of equal survival curves, log-rank test was used. Kaplan-Meier survival curves created to display cumulative mortality over the 28-day period. And median time to discharge from hospital was derived from Kaplan-Meier estimates. And for pre-specified subsidiary outcomes, risk ratio was estimated. During statistical analysis, from the beginning, from the outcome, it was hypothesized that any beneficial effect of REGEN-COV would be larger among seronegative participants. And consequently, the trial steering committee specified that hypothesis testing of the effect of REGEN-COV on 28-day mortality and also secondary outcomes would first be done only in seronegative patients. 28-day mortality in seronegative versus seropositive participants was done by performing a test for hesperogenicity. The full database is held by the study team and analysis done at Nuffield Department of Population Health, University of Oxford, United Kingdom. Appropriate sample sizes could not be estimated when the trial was being planned in the initial state of COVID-19 pandemic. Over 9,700 patients recruited to the REGEN-COV comparison group up to April 2021. The trial steering committee determined that more recruit unlikely to increase reliability of the results materiality. So the statistical analysis plan was finalized and published on 21st May 2021, and recruitment to the REGEN-COV comparison was closed on 22nd May 2021. Analysis was performed using SAS version 9.4 and R version 403. Now this is the trial profile flow of participants through the recovery trial. Total recruited patients were 24,343. REGEN-COV unavailable and or considered unsuitable for some patients. So number of eligible randomization to REGEN-COV was 11,464. That is 47% total of total recruited patients were eligible for randomized to REGEN-COV. Among them, more than 4,800 patients assigned to convalescent plasma group. So number randomized between REGEN-COV and usual care patients was 9,785 patients. That is 40% of the patients eligible. Among them, 4,839 patients allocated for REGEN-COV and 4,946 patients allocated to usual care alone. And 90% of the patients with REGEN-COV group completed follow-up at time of analysis received REGEN-COV. 28 withdraw the consent, 374 proceed to second randomization. Ultimately, 4,839 included in 28-day intention to treat analysis. And among the usual care, 18 withdrew consent, 535 proceed to second randomization, and total 4,946 included in a 28-day intention to treat analysis. Now the results of the study. We already know that 11,464, that is 47% of 24,343 patients enrolled in the recovery trial. Among them, 4,839 patients were randomly allocated to REGEN-COV, and 4,946 were randomly allocated to usual care. Mean age of study participants was 61.9 years with a standard deviation of 14.5, and median time since symptom onset was 9 days. Interquartile range 6 to 12 days. 5,272, that is 54%, were seropositive at baseline. 3,153, that is 32%, were seronegative, and serostatus was unknown for 1,360 patients. That is 14% patients were serostatus unknown. This is the table showing baseline characteristics of first seronegative patients and all participants by treatment allocation. We see that age of seronegative patients, including in REGEN-COV, was 63.2, usual care was 64, and all patients age was, median age was 61.9. We see that most of the patients are less than 70, and some patients were 72, more than 80 also. Here shows that male predominant in all the group. That is, most of the patients were male, but among the women, there was 25 pregnant women. And ethnicity, most of the patients was white, but Black, Asian, and minority ethnic was also included. There is some patient with Black, Asian, and minority ethnic. A number of days since symptom onset in case of seronegative patient was 7, and all patients in case one treated to all patients, it was 9. A number of days since admission to hospital was 1 to 2 days. This is the another part of table showing baseline characteristics of seronegative and all participants by treatment. Here shows the respiratory support received. We see that most of the patients received simple oxygen, that is low flow oxygen, in also seronegative patients and all participants. Some patients received non-invasive ventilation, and few patients received invasive ventilation also. And this, previous comorbidities, regarding previous comorbidities, diabetes predominates in all group. Also, heart disease and chronic lung disease is not far behind. This is the third part of the baseline table showing SARS-CoV-2 PCR result and antibody test result. We show showing that seronegative patients, seropositive patients, and also missing patients. The table shows that most of the patients received corticosteroid. More than 90% patients in all group, 91, 92, 94, and 94% patient. That is, patient in usual care and patient in REGEN-COV group, all patients, most of the patients received corticosteroid. And also some patients received other randomized treatment such as azithromycin, colchicine, and aspirin also. Now the results. The follow-up was completed 4,773, that is 99% in the REGEN-COV group, and 4,899, that is 99% in the usual care group. That is, both group follow-up about more than 99% patients. Use of other treatments for COVID-19 was similar among REGEN-COV and usual care, with about 1/4 receiving remdesivir and 1/7 receiving tocilizumab. See this, that most of the patients of this group also receives other treatment, and about 1/4 receive remdesivir and 1/7 receive tocilizumab also. Patients who were seronegative, REGEN-COV was associated with a significant reduction in the primary outcome of 28-day mortality compared with usual. 24% of the 1633 patients in the REGEN-COV group died, versus 451 died in the 1520 patients in the usual care group, that is 30%. Rate ratio was 0.8 with 95% confidence interval. P-value is 0.001. So, REGEN-COV 99% follow-up and 24% 28-day mortality. Whereas in usual care 99% follow-up, 30% 28-day mortality. This table showing effect of allocation to REGEN-COV on key study outcome among seronegative participants. Here shows all the outcomes of seronegative participants. Primary outcome at mortality at 28 days was 24% in REGEN-COV group and 30% in usual care. When the secondary outcome, we see that median duration of hospital discharge is also less in REGEN-COV group, that is 13, whereas in usual group it was 17. And discharge from hospital within 28 days is also better in REGEN-COV group, showing that it is 1046, that is 64% in case of REGEN-COV group and 58% in case of usual care group. Invasive mechanical ventilation or death, this is also reduced in REGEN-COV group. When we see the subsidiary outcomes, use of ventilation, both non-invasive and invasive, was less in compared to usual care. So, replacement therapy is more or less similar in both groups. We have seen the results with seronegative patients, but the proportional effect of REGEN-COV on mortality differs significantly between seropositive and seronegative patients. Among all patients randomized, there was no significant difference in the primary outcome of 28-day mortality between the two randomized groups, whereas 944 patients died in REGEN-COV group when all participants was analyzed, that is 20%, and 21% died in case of usual care group. This is statistically significant. Among all participants, there was no evidence that the effect on mortality varied depending on concurrent randomized allocation to azithromycin, colchicine, or aspirin. All interaction p-values was more than 0.1. So we see that all patients with REGEN-COV died 944 patients. All patients on usual care died 1026 patients. That is 28-day mortality is 20% in case of REGEN-COV group when analysis done on all patients, including seropositive, seronegative, and unknown status, more or less same. Effect of allocation to REGEN-COV on 28-day mortality. Here we show seronegative versus seropositive participants with Kaplan-Meier curve. Here show that usual care patients mortality and REGEN-COV mortality in case of seronegative patient. It is shown that clearly REGEN-COV patients has less mortality than usual care patients. But in case of positive patients, seropositive patients, REGEN-COV and usual care patient more or less similar mortality. And when all participants is evaluated in analyzed, usual care and REGEN-COV show more or less similar mortality. Rate ratio was 0.9 and P was 0.17 on log rank test. From this Kaplan-Meier curve, it is clear that when seronegative, in case of seronegative patients, 28-day mortality. But in case of seropositive patient, REGEN-COV and in case of all patients, if evaluated, REGEN-COV is not different from usual care. Now the forest plot showing primary and secondary outcomes overall and by baseline antibody status. Here we see that seronegative patients has less 28-day mortality, whereas seropositive patients has more, and unknown patients has more or less similar. And when it is evaluated to all patients, it is more or less neutral. And if we consider discharge alive from hospital, it is also in case of seronegative patients, it supports in favor. But in case of seropositive patients and unknown usual care, and in case of invasive ventilation or death, seronegative significant reduction, whereas in seropositive patients and unknown status patients, it is not in favor of the treatment. So this forest plot clearly shows that outcome is less likely with REGEN-COV in case of 28-day mortality and discharge alive from hospital in case of seronegative patient. But when it is considered in seropositive patients or all patients, this is more or like as well as usual care. There are no meaningful differences in progression to renal replacement therapy, non-COVID motility, cardiac arrhythmia, thrombosis, or measure bleeding either in seronegative or overall study populations. Information on potential infusion reactions occurring within the first 72 hours after randomization was collected for 1792 patients in the REGEN-COV group and 1714 patients in the usual care group. The reported frequency of fever, sudden hypotension, and thrombotic events was marginally higher in the REGEN-COV group versus the usual care group, while the frequency of sudden worsening in respiratory status and clinical hemolysis was marginally lower. There were 5 reported of a serious adverse event that is related to REGEN-COV. So the serious adverse event was only 5 that is reported, but initial infusion reactions were more or less similar to usual care group. Now discussion. We have seen that in this large randomized trial, REGEN-COV in anti-SARS-CoV-2 antibody negative patient, that is seronegative patient, reduced 28-day mortality about 1/5. An absolute benefit of 6 fewer deaths per 100 patients getting REGEN-COV. REGEN-COV was also increased rate of discharge alive from hospital within the first 28 days and reduced progression to invasive mechanical ventilation or death in these patients. Benefits were absent in anti-SARS-CoV-2 antibody positive group. And when all patients considered together, including unknown antibody status, REGEN-COV showed no significant difference in all clinical outcomes. So according to this study, any therapeutic use of REGEN-COV in hospital setting should restrict it to seronegative patients. Every patient should serological testing prior to drug administration. And for serostatus evaluation, further evaluation needed for assays with lower costs and lower technological requirements. We all know that monoclonal antibodies are susceptible to the evolution of viral resistance if substitutions in the targeted epitope reduce or abrogate antibody binding. This risk can be reduced by using a combination of monoclonal antibodies that bind to non-overlapping epitopes. Although spike glycoprotein mutations in some variants, that is beta or delta variants, have showed reduced neutralization activity of casirivimab, the combination of casirivimab with imdevimab retains potency against these variants due to inhibitory activity of imdevimab. Note that when this study was done, most of the virus circulating in United Kingdom was alpha variant. So these drugs shows efficacy in alpha variant, but it is postulated that it also will show activity against the beta and delta variant, as it is a combined monoclonal antibody, not overlapping epitopes, non-overlapping epitopes. Now, strengths of the study. This is a very strong study, as it was randomized, have a very large sample size. There was broad eligibility criteria, and more than 99% of patients are followed up for the primary outcome. There is some weakness also. Only clinical outcomes were followed up, but information on virological outcomes was not collected, nor was information on radiological or physiological outcomes. And another weakness is the trial is not blinded, it is open label. And the dose of REGEN-COV used in this study was significantly high compared to those used in outpatient studies. Now the summary. The trial provides the first evidence that an antiviral therapy can reduce mortality in hospitalized COVID-19 patients. And these results support the use of REGEN-COV in seronegative patients hospitalized with COVID-19. So thank you all for patience hearing. This was all about this journal from my side.
Thanks and congratulations, Dr. ZHM Nazmul Alam, for his brilliant deliberation. that studies showing the ray of hope for the world to combat COVID-19. Now the exciting segment of the session, the question answer session. I again requesting all the attendees to have any question to be written in the question answer box or in the chat box. In the meantime, we have few questions. First of all, to the speaker, what is the meaning of seropositive and seronegative? Though he has mentioned, but for the clarification of the attendees, I think you should mention it again.
Thank you for the question. Actually, I have showed that all the patients, when randomized, before randomization, was evaluated for presence of anti-SARS-CoV-2 antibodies. That is whether the patient has antibody against SARS-CoV-2 virus or not. The patients who have antibody against this, the patient was categorized as seropositive. And the patient who don't have any antibody against SARS-CoV-2, they were labeled as seronegative. Some patients whose test was not done or not known, they were grouped as unknown. But most of the patients was labeled as seropositive or seronegative before randomization. Thank you.
Thank you for your nice answering. I have some questions regarding the monoclonal antibody. I will ask Professor M.A. Forrest, sir. Sir, how monoclonal antibodies working